Bismillah ar-Rahman ar-Rahim. Our presentation today is about malrotation. We will talk about history, embryology, clinical manifestation, radiology, and treatment. Abnormal rotation and or fixation of bowel during fetal life are responsible for the full spectrum of intestinal rotation, abnormalities, and congenital internal hernia. All of us knows the steps or the phases of bowel development during fetal life. There is multiple stages: herniation, rotation, bowel retraction, then fixation. Any variation in this sequence will lead to abnormal rotation, or we will talk briefly about history. Before 18th century, there is multiple description of bowel necrosis after autopsy or during surgery, but the true mechanism and pathophysiology of this disease not understood. In 1898, Moll described the process of rotation and fixation in the human embryo. Then in 1923, Dot published first paper about clinical correlation of malrotation. In 1928, Wow described two cases of Voldulas due to malrotation. In 1936, Ladd described the surgical correction of malrotation. Epidemiology, autopsy series suggests that the malrotation occur from 200 from 1 to 100. They had some type of rotation abnormality, but actual clinical presentation is only 1 from 5,000 cases. 80% cases present in the first year of life. This disease affects male and female equally. Associated abnormalities, 30 to 60% of cases, they had associated anomalies: intestinal, mecal, diverticulum, or other vitelline duct abnormalities, intussusception, Hirschsprung disease, mesenteric cyst, motility disorder, atresia, biliary atresia, abdominal wall defect, gastroschisis, omphalocele, congenital diaphragmatic defects like congenital diaphragmatic hernia, congenital heart disease, heterotaxia syndrome. The malrotation in this syndrome reached up to 80%. Embryology. During 4 weeks of development, actually, there is rapid growth period leads to change in embryo shape from flat trilaminar disc into cylinder shape. This happened actually because folding. All of us know that the folding is, we have two types of folding: anterior posterior folding and lateral folding. Bilateral folding, the bowel will be formed, primitive gut will be formed. This gut divided to three parts: foregut, midgut, and hindgut. Actually, the midgut continue connecting to the yolk sac with vitelline duct. In the 6th week, the midgut appear as a loop. This loop is divided by SMA, superior mesenteric artery, the vessel of the midgut, by divided to two parts. Cephalic part will give distal duodenum, jejunum, and part of ileum, and caudal part will give distal ileum, cecum, appendix, ascending colon, and proximal 2/3 of the colon. Because the abdominal cavity did not accommodate the rapid growth of the midgut will herniate through the umbilical cord and will complete development outside the abdominal cavity. The two loops, upper loops and lower loops, upper loop cephalic loop and lower loop caudal loop, will rotate 270 counterclockwise around the SMA. The axis is SMA. This rotation is divided into 3 stages. Each stage rotates 90 degrees. Here the cephalic part yellow and caudal part orange. Now the first 90 degree, we will see it's after herniation happened outside the abdominal cavity. We will see that the upper part became to the right side of lower part. The second 90 degree will put the upper part down and upper part up. The third 90 degree will make the upper part to the left and lower part to the right. After that, there is rapid growth of the cephalic part. This will give up mainly the small bowel. Then fixation, retroperitoneal fixation of ascending colon and descending colon, which start during this phase, about 12 weeks of gestation after retraction of the bowel and completing of rotation. And this fixation continue until post-term. After this normal rotation of the midgut, bowel appearance will have normal wide mesentery base from ligament of trides to the cecum, C shape of the duodenum. The duodenojejunal junction will be to the left of the midline, this midline to the left of midline, and the level of duodenojejunal junction in the level of gastric outlet. This is the gastric outlet. This is duodenojejunal junction, should be in the level of gastric outlet. This is the normal bowel rotation and fixation, and ascending colon fixed retroperitoneally and descending colon fixed retroperitoneally as well. If malrotation happened, there is a spectrum of malrotation and abnormal rotation or abnormal fixation, but the most common is incomplete rotation, this picture. We will see here that the rotation is not completed and the duodenum did not take the C shape, and the duodenojejunal junction to the right of the midline, the cecum in the middle of the abdomen and free. The ascending colon is free in the abdomen and descending colon as well. There is abnormal fixation of the cecum here to the posterior abdominal wall. These lats bands, these bands compress the third part of duodenum. Here the base of mesentery narrow. This narrow mesentery will put the midgut, will make it unstable, the midgut, and will put it under the risk of twisting and obstructing of the main blood supply, which is the superior mesenteric artery. And if the diagnosis and management is late, will lead to whole midgut necrosis. If abnormal fixation happened, we have mainly two types of abnormal fixation, which called Paracolic Hernias, right Paracolic Hernia or left Paracolic Hernia. This actually congenital internal hernia. In right Paracolic Hernia here, we will see that there is malrotation and there is sac here containing the small bowel with lat bands. Actually, the treatment of this type of abnormal fixation is releasing of lat bands and the colon, and then opening the sac from lateral side here and eradicating of this space, potential space, which make bowel entrapment. In left Paracolic Hernia, we have another issue. Here, the inferior mesenteric vein within the anterior wall of the sac. This should be clear, and we should be careful to not injure the inferior mesenteric vein during correction of this abnormality. Here, we should pull the bowel and evacuate the sac totally, and then closing the opening. Clinical manifestation: acute midgut volvulus. This is the most acute and most dangerous and most well-known presentation. Chronic midgut volvulus, if the volvulus incomplete on and off. Pure duodenal obstruction without volvulus. Reverse rotation rotation with colonic obstruction because of if reverse rotation of bowel, if happened clockwise, will compress the transverse colon and make acute or subacute transverse colon obstruction by compressing of the mid of the transverse colon by duodenum and subarachnomesenteric vessel. Internal hernia, we talked about it, and volvulus of cecum. Most important presentation and most emergency presentation is acute Midgard volvulus. The narrow pedicle here, formed by the base of mesentery in the malrotation, predisposes the midgut to clockwise twisting from the duodenum to transverse colon. Here, the base of mesentery, it's narrow. Stability of the midgut will be affected. For that, this patient prone to be twisted, and volvulus may. This volvulus will obstruct the main vessel, subarachnomesenteric artery. If the diagnosis is late, will lose whole midgut and midgut necrosis. This study in 74 patients to see the age of presentation of midgut volvulus. They found that 90% of patients will present in the first year of life, and 30% of patients will appear in the first week of life. So midgut volvulus happen in sudden onset of bilious vomiting in previously growing normal baby with sign of upper intestinal obstruction. After that, if late, bloody vomiting will develop and bloody stool. If we delayed the management and diagnosis and management, patient will progress distension, bowel necrosis, will make peritonitis, acidosis, and shock. Any sudden onset of bilious vomiting in previously well neonate, we should consider it midgut volvulus. First of them. Chronic midgut volvulus, it's happen if intermittent or partial midgut volvulus. Actually, it's more common in older patients, more than 2 years. Presentation intermittent vomiting, maybe bilious or non-bilious, colicky abdominal pain, diarrhea due to malabsorption, and sometimes routine losing enteropathy, hematemesis, constipation due to dysmotility, malnutrition, and chylous ascites. Pure duodenal obstruction without volvulus is due to compression of the third part of duodenum, plus minus kinking of duodenum. The presentation may acute in neonatal period or chronic subacute, usually during infancy to preschool age. This compression of third part of duodenum happened because kinking of the duodenum and plus and possible the lat's band. Reverse rotation with colonic obstruction. There is signs of acute or chronic transverse colon obstruction. Very rare variant, usually presenting during adulthood. Internal hernia, etiology lack of fixation of mesentery of right or left colon. The formation of potential space for hernias. Recurrent entrapment of bowel with partial or complete obstruction. We talked about it before in previous slide. Volvulus of cecum, etiology lack of fixation of ascending colon and cecum, most often seen in patients older than 60 years, clinically acute abdominal pain and obstruction. X-ray, air-filled dilated loop occupying left upper quadrant. Radiology, the classical presentation of malrotation is bilious vomiting with upper intestinal obstruction. So we can see dilated stomach with paucity of gas distally, or we can see double bubble sign with paucity of gas distally. If volvulus happens, the bowel will be filled by fluid, and the bowel will be dilated, and we can see the gasless abdomen. Other picture we can see in the malrotation and small bowel obstruction, higher or maybe lower obstruction in sometimes, especially in the late presentation. We can see pneumatosis intestinalis or either pneumatosis of the portal vein in cases of late presentation and bowel necrosis. Ultrasound study is good screening device studying the relation between superior mesenteric artery and superior mesenteric vein. Normally, the superior mesenteric artery it's located to the left of superior mesenteric vein, anterior to the third part of the duodenum, and the aorta located behind the third part of the duodenum. If the relation, in the malrotation, the relation there is between superior mesenteric artery and vein will be changed and reversed. In case of volvulus, we will see the whirlpool sign in case of volvulus. This is the flow pattern of superior mesenteric vein and mesentery around superior mesenteric artery. Fluid-filled distended duodenum, thick-walled bowel lobe located mainly to the right of spine. Ultrasound sensitivity in detection of the malrotation is 87% and specificity 75%. Positive predictive value 42% and negative predictive value 96%. And whirlpool sign, it's sensitive in detecting of the volvulus, it's sensitive in 45% and specific in 99%. Contrast study, this is the best diagnostic method. In normal rotation, we will see that C-loop, C-shaped duodenum, the duodenojejunal junction to the left of the vertebra, midline, and in the level of the gastric outlet. In malrotation, here, the duodenojejunal junction to the right, this is typical malrotation, to the duodenum did not take the C shape, the duodenojejunal junction to the right side of the vertebral column or midline. In case of volvulus, we can see the bird beak appearance or corkscrew sign. Malrotation may be typical or atypical. Typical malrotation in radiological classification, typical or atypical. Typical malrotation, it's the duodenojejunal junction will be to the right side or to the right of the midline here in this quadrant. But atypical malrotation, the duodenojejunal junction may be in the midline or in the left lower quadrant. That means it's low, not in the level of gastric outlet. So I will repeat: typical malrotation, the duodenojejunal junction to the right side of vertebral column or absent. Atypical in the midline or in the left side, but below the level of gastric outlet. This study about malrotation beyond infancy. Actually, it was a retrospective study in 38 patients. 35 was pediatric and 3 adult. The patient all patients age above 1 year, and they found 50% of patients, the age of patient between 1 and 2 years. 75% of patient age below 5 years, and 3 adults. The ultrasound was diagnostic only in 1/3 of cases. Upper GI contrast study was diagnostic in all patients. In this study, they found that all midgut volvulus happened with typical malrotation, and 3 adult patients, they had volvulus. 2 of them, they had volvulus, and 3 of them, they had typical malrotation. And these 3 patients, they don't have adult patient, they don't have other symptoms previously. Older patient between above 2 years, 1/3 of them, they had atypical malrotation, 2/3 of them, they had typical malrotation. Above 2 years, there are atypical clinical presentation. Interestingly, they found that 5 of these patients treated as a TB because the TB endemic in this area. And this patient, they had congested bowel, enlarged mesenteric lymph node, and ascites. After referral to surgeon, they did upper GI contrast study and found this patient had malrotation and improved after surgery. After 2 years, 2 of patients had pancreatitis. Actually, the pancreatitis and sometimes jaundice happened because compression of third part of duodenum and may affect the drainage of pancreas and make jaundice, sometimes pancreatitis, very rarely. And these two cases, the MRI of pancreatic and biliary tree was normal. So in this study they reviewed there was good literature review, and they found in atypical malrotation, the persistence of symptoms in 40% of. Actually, the conclusion from this study, all patients with acute or chronic abdominal signs should be investigated for malrotation. All typical malrotation, regardless the age, should be corrected surgically to avoid midgut volvulus, regardless the age. Treatment: infant with suspected midgut volvulus, depending on X-ray only, and the clinical findings will require rapid resuscitation within 2 hours with NGT and IV antibiotic, then laparotomy for preserve intestinal viability. Operative technique of LAD procedure: right upper transverse laparotomy, evisceration of bowel and inspection of mesenteric root, counterclockwise detortion of the midgut, lysis of peritoneal bands with straightening of duodenum, widening of the base of mesentery, appendectomy, then placement of the small bowel on the right side of the abdomen, and cecum in the left lower quadrant. A localized gangrenous segment may be resected and primary anastomosis performed. A second look laparotomy should be performed when there are multiple areas of bowel of questionable viability, the entire midgut appears non-viable, clinical signs and symptoms suggest progressive loss of intestine. Post-operative complications: short bowel syndrome, post-operative intussusception, adhesions, recurrent midgut volvulus in less than 0.5%. Thank you. Actually, paracolic hernia occur because abnormal fixation of either ascending colon or descending colon. This will make like a space, like a congenital internal hernia, and the small bowel goes inside this space, and this will make like compression of the bowel and obstruction or sub-obstruction of the bowel. Atypical malrotation. Okay, I spoke about atypical malrotation before. It's typical malrotation. The duodenojejunal junction will be to the right side of the midline of vertebral column, but atypical malrotation either in the midline, the duodenojejunal junction, or to the left in the midline but low, not in the level of the gastric outlet. If malrotation becomes symptomatic, we call it volvulus, right? Elective surgery? No. If the malrotation is symptomatic, but we exclude volvulus, we should do the surgery within 24 hours. Not very urgent, but we should not delay the surgery more than 24 hours.
I'm following you in the question, Dr. Safi. Jazakallah khair. You are doing the best. Okay.
If malrotation becomes symptomatic, volvulus, urgent surgery. If malrotation, we should surgery. Typical malrotation, with or without symptoms, surgery. Atypical malrotation with symptoms, surgery. Approach and management of incidental chylous ascites during elective surgery. Approach and management of incidental chylous.
If you did inguinal hernia and you find chylous ascites,
we should make full workup. One of the workup excluding of malrotation.
Very good. And if it is malrotation, you will proceed for surgery.
If there is repair the inguinal hernia, then after that, after 2-3 days after recovery, you can start workup for chylous ascites. Not in the same session make laparotomy, not during surgery. After that, next day, after 2-3 days, do upper GI contrast study and complete all workup for diagnosis of chylous ascites.
Okay. And after that, if you did the contrast and there is malrotation, you will go for surgery.
Yeah, sure.
Right? Yes.
Yeah, right, sure.
Okay. I will brief you the question because sometimes it's repeated. Appendectomy is controversial in large procedure. What are your thoughts regarding the appendix?
Yeah, actually, I found some surgeons did not do appendectomy, but classically, I prefer to do appendectomy because the appendix will be in the left side of the abdomen, not normal place, and this possible will delay the diagnosis and will increase the complication of appendicitis. I prefer to do appendectomy. It's part of classical LATS procedure.
What is your method for appendectomy? Is it formal?
Formal, yes. Formal.
Formal appendectomy, yeah. Very good. Same, they are asking about the asymptomatic, as you mentioned. At any asymptomatic malrotation, you go for surgery.
Even if asymptomatic, but discovered during any investigation or during surgery, if typical malrotation, we should do surgery because typical malrotation, it's had risk for volvulas, even if not symptomatic during life. If one person 35 or 40 years, he had typical malrotation, even previously not symptomatic, we should do surgery, surgical correction of it.
Very good. One of the questions he asked about the whole gut non-viable. He mean if you went for Midgard volvulus and you found a whole gut is non-viable.
Yeah, it is, actually, this is a difficult question, and it's related to the place you are working. First of thing, you should give the patient chance for second or third look. If you have facility for bowel transplantation, you will remove all necrotic bowel, and this patient will be candidated for bowel transplantation. But I don't know if you are in places the bowel transplantation not available, the TPN, it's difficult. It is related to multiple situations. But if you have bowel necrosis, it's remove and the patient for bowel transplantation. This is
very good. Super. Yeah. Just for the attendee, please put your questions in the questions part because I cannot read all the chat and the questions. Sorry for that. So another question: if you had asymptomatic patient and after that contrast, when you will do the repair in the same admission or as elective admission?
Asymptomatic.
Asymptomatic.
Same admission. I prefer same admission. Same admission. Don't discharge the patient with typical malrotation, even if asymptomatic.
Okay, another question. Can malrotation beyond infancy present with non-bilious vomiting always or never bilious?
Yeah, good question. Not always bilious vomiting malrotation. It's usually bilious vomiting, but a good number of patients treated as a GERD, and then they found this patient had malrotation because there is distal sub-obstruction and make high pressure in the stomach, and this patient will had non-bilious vomiting and had secondary gastroesophageal reflux. So not all patients, they had bilious vomiting. Classically, they had bilious vomiting, but not all patients had bilious vomiting, okay?
Okay, very good. Another question about the congenital diaphragmatic hernia associated with malrotation.
Yeah.
Did you look for it and did you repair it?
Actually, in congenital diaphragmatic hernia, they had a good number of them. They had non-rotation type. The base of mesentery is wide in this patient. For that, in this patient, we did not do anything for this patient. Number one, the situation of patient is like semi-critical, and other things. In this patient, usually the base of mesentery is wide. The third thing, I think, after surgical repair, patient he will had adhesions, and the risk of Midgard volvulus is very, very minimal.
Very good. Thank you. Yeah. Type. Another question. Don't we place the cecum in the left upper quadrant?
Don't we place cecum in the left
upper quadrant?
No, actually, into the left side.
Colon.
The whole colon in the left side. It's mobile. You cannot say in the left upper or left lower. You will put colon in the left side, small bowel in the right side. You cannot say upper or lower.
Last question.
Sorry, yes. The surgical correction is to make non-rotation type. widening of the mesentery and convert from partial rotation or incomplete rotation to non-rotation type. Okay,
Yes,
this is the
non-rotation.
idea. Yeah, non-rotation type.
Okay, Dr. Ali, he asked about the treatment for atypical malrotation. Is depend on symptom or not, and why the difference in the treatment between right and left paracolic hernia?
The treatment of atypical malrotation. I think if atypical malrotation symptomatic and the symptoms cannot and the symptoms maybe related to the malrotation, we should treat it. But if asymptomatic, I think we can watchful observation of the patient. They found most of the Midgard volvulas happened in typical type of malrotation. This number one. Number two, they found that after surgical correction of atypical malrotation, there is good number, in some study reached to 40% of patients, there is persistence of symptoms, not totally improved. For that, we have judgment during treating of atypical malrotation. Okay. And why difference in treating between right and left paracolic hernia? We said that in actually, it's very rare abnormality, and in the right side, as we noticed that it's happened with malrotation. For that, we should do malrotation correction plus eradication of this space. For that, releasing the colon, cutting of that bands from laterally, and this will eradicate the space and will correct the malrotation. And left side, left paracolic hernia, there is the inferomesenteric vein, the wall of the sac. For that, we should preserve the anterior wall of the sac, but we should eradicate of the sac or by pulling the small bowel and closing the opening with preserving of the anterior wall because it's containing the inferior vessel, mesenteric vessel.
Okay, I have just two questions if you don't mind, Dr. Safi.
No problem.
Are you happy?
If we have time, I'm happy.
Type. What do you prefer? Would you prefer inversion appendicostomy or appendectomy?
Yeah.
Inversion.
Some people doing inversion, but I think it's a classical appendectomy. It's a good option.
Last question, please. What is the surgery for reverse rotation?
I did not face any case with reverse rotation, but I have read about it. Two options. One said resection and reanastomosis of the colon, but I think I found some people, they said only releasing of the colon and pushing it, releasing of the colon from right side, pushing it to the left side, like reflection of the colon, and the duodenum with adhesion, releasing it from the colon and pushing it to the right side. Actually, I don't have experience. It's the correction, either resection of the colon or releasing of adhesions between the duodenum and vessels and transverse colon.
Super. Thank you very much, Dr. Safi, for your time. Some of them, they said you dismissed my question. Sorry if it is repeated or if we don't have time. Actually, I will just dismiss because we have a lot of questions.
No
really,
thank you. If I have time, no problem. Thank you.
No, we finished. We finished, Alhamdulillah. We finished all the questions.
Thank you so much. Dr. Abdullah. Shukran for attending. Okay, thank you so much. See you, inshallah.
Thank you. If you have any questions for Dr. Safi, if you not answered in the presentation, you can see our this account, Pediatric Surgery Review account in the Twitter. You can ask all the questions there, and if we have time, inshallah, we'll submit it to Dr. Safi to answer it. Thank you very much for that.